Good morning everyone and welcome to the Health Overview and Scrutiny Committee meeting on Monday the 27th of April. Welcome you all and thank you so much for your time this morning. Agenda item 1 is apologies and any subs. I don't think we have any, do we?
Not on the HOSC, no subs. No. Yes, Chair, we have got apologies from Councillor Bakul Kumar and Andy Fry.
Thank you very much. And Dr. Lisa McNally will be coming along. She's just got a prior meeting that she's attending. Thank you. Agenda item 2, declarations of interest, please, and any party whip. There is none. Thank you very much. Public participation, we don't have any. So I welcome Jeffrey. Welcome, Justine, to this Health Overview and Scrutiny. I don't know if you've been in here before, but it's great to have you. And I'm handing over to you on maternity, newborn, and the first 100 days, please. I'm sorry, I've jumped straight ahead. I've got to do... It's not on my agenda item, further down.
My apologies.
Please. Look at the minutes of the previous meeting. It's not on the agenda. That's why I haven't covered it. Everybody happy? I'll sign them off as a true and accurate record, please. Because we have 2 lots, one from the 4th of March and one from the 11th of March. Are we happy with those? I sign them off, please? Yep, thank you very much. Justine, sorry to keep you waiting. Over to you.
It's okay. Good morning. Thank you very much. Thank you for inviting us back. It's been a number of years since we've been to the Scrutiny Committee. It was last in 2023, when we were probably in quite a different place than we are now. And you'll see from the paper, obviously we're not going to go through the paper again because we'll take that as read, but I do want to point out some of the improvements that we've made over time. So we were very pleased that not shortly after we last came to the committee in 2023, we had a CQC visit and we were rated good, which reflected all the really hard work that the team had put in over that last 2 or 3 years. So you'll also see from the paper that we also then were able to step off the NHS England support programme because we continued to make good progress and we stepped off that in 2024. You'll see from the heat map results that we're currently sitting in the top 10 out of 21 trusts within the Midlands. And if we continue to make the progress we expect, we'll drop a further 7 points, which means that we will have a score of around 13, which will put us in the top 3. So we've got a little bit of work to do, but that is just around recruitment. So we need to employ 7 support members of staff, a dietitian and a couple of midwives, and we will remove those 7 points. So it's we're reporting quite a good place. That's not to say that we don't have some challenges, and you'll see within the report the sorts of things that we're working on at the moment. Predominantly working with our users to improve some of their experiences, particularly around our triage department, waiting times to see medical staff, and our induction of labour pathway as well. So those are some focuses that we've got at the moment. You'll also see within the report that more recently we've had to do some work around home birth. There's been a lot of interest in the press of some high profile cases in the last 12 months where we've had a number of sad, poor outcomes for women giving birth at home. And following the publication of a Prevention of Future Deaths notification at the end of last year, NHS England asked us if we would review our home birth service. So we again were in quite a fortunate position in that we've got a number of teams that we could consider to just try and restrict the number of people who were involved in home birth and transferred the care of all our women who were requesting home birth to our continuity of carer teams, who will look after the women right from booking right through to when they give birth and then beyond into that first 28-day period when midwives then hand over to our health visitor. So by doing that, it just means that we can make sure that it's much more sustainable. It also means that we can focus training on a small group of people and make sure that they have all the skills, the regular updates, and that they're equipped and the most prepared to provide intrapartum care in that environment. So that's the first part. You'll see also within the report, and a lot of the following work that I'm going to talk about has been really supported by our public health colleagues. We had some funding about 2 or 3 years ago to employ some public health midwives, and later on then they went on to be funded by the trust. That meant that we could focus on smoking, obesity, vaccinations and infant feeding, all the things that we have seen have been quite challenging at times, and there's still a little bit of work, as I say, to do in some of these areas, but there are some good news stories here as well. So about 8% of our women are still smoking at the time that they book in pregnancy, which is disappointing at the beginning, but we do have a really good uptake for our smoking cessation services, and that has led to us reduce the number of women who are still smoking at the time of birth by 50%, so that's about 4% now, so that's excellent, and that's where we would like it to be. We also managed to secure some funding from NHS England so that we could employ some vaccinators, and then we were able to roll out a vaccination service to work alongside midwives, both in the hospital and in the community clinics, to try and increase the uptake of the vaccination programme that you'll see outlined within the report. And you'll see the uptake is quite good there, but there's still work to do. And we just want to make sure we've got as much reach as possible across the county. From an infant feeding perspective, we're really fortunate to have 3 lactation consultants in our infant feeding team. We've been able to support them to all achieve that level of knowledge and experience and have a certification for that. They also provide frenulectomy clinics across the county with about a 2 to 3 week wait at the moment. We'd like it to be 2 weeks, not 2 to 3 weeks, so we are working on that. But that will help mothers who are struggling, because alongside the frenulectomy clinic, it's also, we focus on complex feeding issues as well. So that hopefully will help women who choose to breastfeed to continue to breastfeed. And you'll see there the rates. There is some work that we could do, because it does fluctuate very much between about late 60s to top 70% breast milk as the first feed following birth. In terms of obesity, we do have quite an increasing population of women who have a raised BMI, and that causes a number of issues during pregnancy. So we started a pilot by our public health midwife called Blooming Healthy, and she has been undertaking clinics and working with groups of women for a couple of years now. Again, it was a pilot that was started with the support of our public health colleagues, but was able to continue, and we're looking now to develop that further with some lifestyle coaches that will be able to support that work, because the early indications are that's having quite an impact and helping people at least maintain, if not reduce, their weight during pregnancy. So we want to continue with that. So when we last spoke to you, I think 3 years ago, we were working our way through, if you remember, there's a number of national reports that had come out over the previous 10 years. And we'd had 2 Ockenden reports published after the findings from Shrewsbury and Telford. There were over, at that point, about 500 recommendations for maternity services to work through from a number of other national improvement documents alongside the Ockenden reports as well. And we're happy to say that we were able to achieve all of those recommendations, and those action plans were then archived by our trust board once completed, because this maternity single delivery plan was then published and superseded the Ockenden reports and other reports that were published over the previous 5 years. And it was a recognition that there were so many recommendations that in itself was a risk to try and manage. So the single delivery plan was published with the aim to try and distill those and make it easier for services to focus and complete those actions. That was a 3-year-long improvement document, which now has completed. We have just sent our final submission to our ICB and regional colleagues. We had a national dashboard that we were able to see our progress. Early indications are that we succeeded in lots of areas within that, within the single delivery plan. But as we say, there is always work to do, and we will always continue to make those improvements. So where we are now is, we think, in a fairly good place, but we need to continue to make those improvements and sustain them. We have got a number of publications, I'm sure you're aware, about to be published. We've had the interim AMOS report, and we expect the full report in the summer, alongside the Thirlwell inquiry report, and also Donna Rockenden's report into care of families in Nottingham. So there is further reports coming, and we'll manage those in a very similar way to we have done before, in that we'll take those recommendations, benchmark our current place, and then work towards achieving the recommendations as outlined within the reports. So I'm going to pause there and happy to take any questions. Thank you.
Thank you very much indeed, Justine, for taking us through the report and for the work that's gone to date. I know where this service started and I know the upward trajectory it's on. So, questions. We have several people wanted to ask questions, starting with Councillor Tom Wells, please. And
Thank you,
Councillor
Chairman.
Preston.
Good morning, all, and thank you for your attendance today. I would just want to focus on home births, if I may. Have you data that compares home births with more routine hospital births? And what is the direction of travel in terms of the number of people proportionately who are receiving opportunities to birth at home? And what does the NHS say to potential mums when they express a desire to have their baby at home? 3 questions there. Thank you.
So yes, we do. We have a maternity dashboard that provides us with outcome data for all of our births. Women who choose to home birth at the moment form probably around 1% of our entire birth, so it's a very small number of women, which again makes it more difficult to manage and to maintain a safe and a sustainable service, which is why we made that change to have much smaller teams, much fewer people involved in providing that service. When we first meet families at the onset of their pregnancy, we are obliged to provide them with all of the options around their place of birth, whether that be home birth, birth in our birth centre, or birth in our obstetric consultant unit, and all the risks and benefits associated with that, so that they can make a truly informed decision. And so that is discussed with them at various points throughout the antenatal pathway, so booking, then again at around 36 weeks, and then again at the onset of labour.
Can I just quickly follow up? Thank you. So my follow-up question is, if you look at the performance data for babies born at home in comparison with the other 2 options, what does it tell us about I don't know, the mortality rates, sadly, the infant mortality rates associated with those options?
So depending on the risk stratification of the woman and the choices that she makes during her labour, the outcomes will vary. There are very small numbers. If you are a low-risk midwifery-led woman with no pre-existing health problems, it is actually safer if it's your second baby to have a baby at home. It's actually only very slightly more complicated or risky to have your first baby at home than it is to have your baby in hospital. So home birth per se is not a risk factor to cause or lead to perinatal mortality.
No, you just, Chairman, if you could indulge me, I think we've just heard something I wasn't expecting to hear. So all things being equal, yeah, it's marginally safer to have your baby at home. Is that what you're saying? With all those risks.
If it's your second baby.
If it's your second baby, message out there
Yeah.
from the NHS today is actually it's safer to have your baby at home. Now that's amazing.
As long as your first pregnancy was uncomplicated.
Okay.
I think
With
it's
those
really,
belts and braces.
Yeah, really important. You have to have had a straightforward pregnancy.
And do the NHS convey that then to would-be mums?
Yes, we do.
It's safe to have your baby at home. Is that
information is
I mean,
vague.
some people might misinterpret that and think actually hospitals are not safe environments then. Like for like. I don't know. I'm the Mirror news editor here, writing my headline.
Yeah, I think what
I
we
think stick
what we
to the
need
day
rem-
job.
Yeah,
I think the mum's at the centre of this, and
Yeah.
wherever the mum feels the most confident in having her baby, then that's where the mum should be based to have the baby. But thank you. I'll put you on the list, Councillor McSweeney. I've got Councillor Turner. Okay, Councillor McSweeney. Yes, carry on.
Excuse me, I was just going to comment on the statistics. I'm always thinking statistics here about in terms of the, when you're saying this about it's safer in terms, this is a statistical thing, are you separating out in terms of it's not a consistent, those who choose to have home births, you've already got a selection in terms there. So I'm just going to query about whether that is accounted for in these statistics you're telling me here, and how well is that accounted for, that there is already some selection, they are not the same cohorts.
no, they're not, and that's taken into account in the study. What I can do is send the study and share that with members if that would be helpful.
It's very interesting. It's all these males interested in home births when they don't have to do the labour. Thank you very much. So I've got Councillor Turner, please.
Yes, thank you, Chair, and thanks for the report. You mentioned earlier about how the authority has improved in recent years and so on, and I just wanted to refer to a national survey, and postnatal care in the UK has been described as a failing service. Services highlighted critical system issues, leaving many now mothers feeling unsupported, and which is sort of contrary to what you just described to us. And sometimes with various scrutiny committees I come to, it's always a very positive outlook. Forgive me for being sceptical, but obviously this national survey is the direct opposite from what I've been described to today. I wonder if you could just shed some light on how you feel this health authority is comparing with outlying authorities, which I am on the border of, which comes under Dudley or Birmingham. And obviously something is at odds, and I just wonder if you could shed any light on that for me, please.
Yeah, I think it's very fair to say that postnatal care is often described, isn't it, of the Cinderella service of maternity services, because unfortunately when there are challenges in the more acute areas, staff will often get deployed from those areas to manage the more acute areas, which does then mean that the experience that women have can fall short of what they expect. And I think we just need to be really careful. So the survey very much talked about women's experience, and that is incredibly important, not that it was the care was unsafe. So what we've seen from our users through our maternity and neonatal voice partnership is quite a lot of dissatisfaction with some aspects of the care that they had within our maternity inpatient postnatal service, bearing in mind that the length of stay is 1.2 days on average, so women aren't with us very long. But during that time it can feel very busy, very rushed, lots of waits to try and get mums home and families home, and you'll see within our own CQC survey there are some areas where we needed to improve, so to reduce delays in getting families home, also access to pain relief. And there is now, in response to that survey, a toolkit that you can use to support making improvements in postnatal care, which we've just received and benchmarked against, and we've got a clear action plan of how we're going to address that in totality, although we had already started making improvements around access to pain relief and delays in discharge. But as I said earlier, there is always more work to do. But it is a very busy, noisy environment, and for some that can be quite challenging.
Do you have a supplementary, Councillor?
I do have other questions, but I don't think it's relevant to what we're just discussing. I'd like to come back a bit later if I can.
Absolutely. Thank you very much. So now I have Councillor Mel Fordington, please.
Thank you. It's a follow-up from Councillor Wells. Okay, it's about home births. Okay, supposing the mother goes into labour early, which happens, and especially being a second child, and she's got risk elements with the baby's, it had complications. So what aftercare, what services are they to actually support that mother from, when she's actually giving birth? And any complications has occurred. So what do you do, especially if they're living in a rural area? So what facilities are there to support this particular bit? Thank you.
Do you mean if she chose to have a home birth but then had a baby early, so had to have a hospital birth, and how we manage that? Or I'm not quite sure I understand your question, sorry.
I'll refrain. It's an early birth, and she's obviously knowing the fact that she probably wasn't going to have any complications, and she's having the baby at home. So what happens? Obviously, she's got complications because she's having an early birth. What facilities are there available for this lady to have her baby at home? Because obviously that she's decided to have early, she's decided to have her baby at home, and of course she's gone into labour.
Okay, so the criteria for home birth is 37 completed weeks. So any labour that occurs before then, women will be advised to transfer into hospital because of the risks associated for the newborn. So, and we do not provide a home birth service for women below 37 weeks. And then her team will support her through the hospital birth into the postnatal period and then back home.
Thank you very much indeed. Councillor Taylor, please.
Thank you, Chair. Morning, all.
Morning.
I'm sort of going to reflect what Councillor Turner says. So I live in Redditch all my life. I was actually born in Bromsgrove because there wasn't a Alexandra Hospital then. But Redditch lost its maternity unit, I don't know how many years ago. My daughter was born in 2010 in Redditch, so I think she was one of the last children to be born in that area. For Redditch residents, it's difficult. I'm sure Councillor Eacott would reflect the same, that we get lots of people saying, why did the maternity unit have to move? So I do question your data, but I question your data on the good rating based on Redditch alone. So I would like to understand, when you have your rating from CQC inspection, what is that data when it's drilled down to Redditch? Because it doesn't reflect the people that speak to me and, their complaints, and they're having to travel to Worcester in the middle of the night, on a busy summer afternoon when you can't get down the M5 quick enough. I'd like to understand the data for Redditch alone, please.
So Redditch Maternity Service moved in 2016 to Worcester, so we're about 9-10 years in now. When CQC come, because the acute service is based at Worcester, they only inspect Worcester from an acute perspective. So what we might see in the future, we don't know, because lots has changed in how CQC are working now, and the frameworks are really quite different. We don't know how or if they will look at the maternity hub at the Alex and the care that's still there. But I think if we just reflect back on what is available to the residents of Redditch and Bromsgrove, is all of their care, antenatal care and postnatal care, can be delivered either at home or at the Alexandra Hospital. There's a day assessment unit there, so they can be seen to sort out minor complications, ongoing fetal assessment, ultrasound scans, testing, etc., early pregnancy care, postnatal care. What they can't get obviously at the Alexandra Hospital, since the acute maternity services moved from there to Worcester, is their care in labour, unless they choose to have a home birth, of course, and then they'll be cared for at home. And that immediate postnatal care, which, as I've said to you, we see about a 1.2 day stay, in that postnatal ward area. More complicated and challenging for families whose babies then might need some extra care, who go to our special care baby unit, or women who need ongoing antenatal care and an inpatient admission, because then that will be at Worcester. And we do recognise that is challenging for people One, for travel. I mean, there's cost associated with all of the things that I've talked about. We try and make sure that all these families have concessions for things like parking very cheaply. We try and support families as best we can. But I hear what you're saying. It's not ideal in their entire pathway, but they do get the large majority of their pathway delivered at the Alex.
All due respect, what I'm asking, the answer for is the data which you've given to say the service is rated as good. How does that reflect in Redditch as part of the trust? Because that's not the opinion I get from a lot of my residents.
If I can just intervene there, overall, because it's an acute service in Worcester, Councillor Taylor, the service will be judged as on Worcester. In terms of the demographic attending the hospital, that could be another set of data that we could request going forwards. How many Redditch residents and Bromsgrove residents go across? I think there are some concerns, Justine, if I'm absolutely honest, about the fact that we don't have this provision in Redditch and Bromsgrove, but I do recognise that historically it was deemed not to be safe to have babies in Redditch over the years. My question, off the back of the question that Councillor Taylor's just asked, is what's the future provision going to look like with the increase of approximately 20,000 homes in the north of Worcestershire, with the future housing growth? How are we going to address that, and what plans are in place now to look strategically at how we will address future generations of people who come to live and have children in Worcestershire, in the north of Worcestershire, please?
And the south.
Well, the south, you're a little bit closer to the issue, and I'm sorry to put you on the spot, Justine, but it is about future planning. And I'm really concerned that when these housing targets come down from the government and they turn around and say, OK, this is what you're going to have to build, at what point you have the opportunity to say, well, actually, if you're building this number of houses, we need several more consultants, we need a whole new unit, etc. And I'm trying to open up that conversation for you to get in at the front end of plan making for Worcestershire.
Hello.
Hayley,
Hi,
please.
Hi, I'm Hayley. I'm the Chief Nurse at Worcestershire Acute. Can I just bring in Mary Gay, who's our ICB MD, please?
Of course, Hayley. Good morning, Mary.
Good morning. Good morning, all. For those who don't know me, I'm Mary Gay. I'm the Deputy Chief Exec for Coventry, Warwickshire, Hereford and Worcestershire ICB. This is a commissioning issue for all services, not just maternity. We are seeing a huge growth in population, and we're seeing a huge growth in elderly in our patch as well. Over 80, it's quite stark in the next 5 years. So we'll be working with the Trust and other providers as well to make sure that the resources are in the right place to deliver the services that we need. Can we deliver everything in every locality? We're not going to be able to in the resource that we've currently got. You've got to match that with the safety and the workforce issues that the NHS has got, to make sure that crucial services like maternity, where you do need a special care baby unit, a fully functioning 24-hour special care baby unit for when things inevitably but sadly can go wrong sometimes, you need that really strong support as the main safety issue for women and children. So, but you know, over the next 5 to 10 years, we're working with public health, we're working with other people in the area to make sure that we have the right capacity and demand in services to meet the future populations.
Thank you very much, Mary, for that. I really do appreciate it. I think the time has come that we look at how we deliver services. And whilst I recognise, and it's really good that you do give preferential parking deals, etc., but it's about that connectivity. And currently our roads are over congested, our access is limited in many instances. And I think the point is, coming from the north, I'd like to see an even playing field. I'd like to see investment into our health services. We lost 200 beds when the last hospital closed in Bromsgrove. We have a community setting that we can go to. We have no GP out of hours access. And I think the time has come with the raising population. If we're going to increase the population by 1/3, I think we should at least develop the services by 1/3. So I'm just going to shout out for this because I think it's really important, and it's about planning, master planning. And all I can ask is, please, I with my district hat on, we don't get enough conversations with health about what your asks are with future housing growth. So I think we need to put that onto the agenda. Thank you. My one question, supplementary off the back of that, Councillor Taylor again, is about workforce. What's the state of retention of midwives currently, please?
So retention of midwives is really positive. The trust run at about, we try and keep the target under 11% turnover, and it's currently around 3 to 4%. I think if you just recall, I did talk about care assistants, and we just needed to employ some more. That is where we see the biggest amount of turnover in our maternity care assistants, and that's why we're constantly replenishing people who come and work with us for a while and then move on. Sometimes they go on because they want to do their midwifery or nurse training, and that's fantastic, but sometimes it's not quite the job they expected to do. So our lead midwife for that group of staff are actually doing some taster days for people who are considering employment with us to try and make sure they understand the role before they're recruited into that role. And remembering as well that they are probably one of the most poorly paid groups of staff within our service. It's the lowest banding available, so it's not always that attractive, and often, you know, we have to compete with some of our competition. You know, sometimes people will tell us they can earn more if they work for some of the supermarkets, and that's quite difficult. But there is an opportunity for people to come in on that banding and then quite quickly move to the next banding when they do additional competencies and have some support and do some training and education that comes along with that, so that it is a pathway into their training potentially as well. So that's what we're trying to promote at the moment. But thank you.
Thank you very much. And working with the university, do we pick off some of the stars and encourage them to stay in Worcestershire?
Yes.
Excellent. That's what we like. We like to grow our own. Thank you very
Indeed.
much, Justine. Councillor Taylor.
I'll just come in on that for two reasons. One, professionally, I run a small recruitment company, but more personally, so my daughter's 15. She's genuinely torn what she wants to do. She's starting her exams, in fact, today. In fact, I need to text her. We should have not. But she's genuinely torn what she wants to do. How do you involve youngsters and encourage them at this? Are you going into schools? I mean, I can only talk about the experience through children and cousins and things locally again in Redditch. I don't see an awful lot of being proactive. So are you going into colleges? Are you going into schools? Is there anything you can do to lead the children to at least consider a career as in midwifery?
Do you mind if I come in? I think there's a lot we can do. So I've been in Worcestershire Acute since September last year, and I worked in a previous chief nurse job where we had probably much better relationships with the local schools. So I think there's a lot of opportunities there. We do work really closely with our local colleges. So I'm sure your daughter knows about T-level training. So we're a really strong advocate for the T-level students. We've got our second cohort going, and that's both for midwifery and for nursing students. So in terms, it's like the old BTEC, isn't it? So that's really positive. I think there's a lot more we can do in that space, because you're absolutely right that we need to grow our own within Worcestershire. And there's a really good opportunity to do that. So for me, there is some work that we could do with our local schools. There's absolutely work ongoing with our local colleges, and that's a really positive relationship. We've also got a very positive relationship with our local universities as well. However, that's a little bit the horse is bolted, isn't it? Because they've already chosen. But we have got a very strong relationship with our university and our colleges. But notwithstanding, there's still some work to do, because in all fairness, most 15-year-olds don't know what they want to do. So I think we need to give people some opportunities. Yeah, I also worked in an organisation where we had a young volunteers programme, and again, was really positive. It was very good for people's CV, but also it gave people a taste. So I think there's a scope to do lots of different things. Thank you.
Thank you very much. Let's hope your daughter goes on to do this.
I hope so.
It's great. So I've now got Councillor Mel Fordington, I've got Councillor Wilde, and then I've got Councillor Paul Harrison, please.
I'm really glad to hear that, actually. I'm the ambassador for apprenticeship programs as a councillor, so I will be welcoming that for definite. So I'll be hearing from you guys if that's okay. Yeah. Okay, I wanted to ask, what's the waiting times for the hospitals as in such? Do you have enough facilities and do you have enough beds?
In terms of midwifery?
In terms of maternity services?
Yes.
Waiting times, we don't have waiting times in maternity services.
Yes, delivery time. Sorry, I meant delivery times. Yes.
Um, So we do have enough inpatient facilities for the women who are currently accessing. Interestingly, I know we've touched on all the building work that's going on, but actually we've seen a reduction in our birth rate over the last 5 to 6 years. We used to see about 5,500 women give birth across Worcestershire, and it's about 4,800 at the moment. So that's quite a significant decrease. So there is some capacity there. Already built in that we do need to consider. The other thing to say is that you'll see within the report I have talked about induction of labour delays. This is something that most maternity services are grappling with, because we have seen some evidence over the last 10 years to suggest that for some women with some complications, earlier induction of labour creates some positive outcomes. However, if you then have an increasing number of women who require induction of labour, inevitably then you get some delays in that pathway. So what we see is we don't delay people coming into the hospital to start the process, but they're all sometimes can become a little bit of a bottleneck at one part of the journey. And that's not a great experience for women at all. And you'll see within the report that we are monitoring that. That sits within our dashboard, and we have seen an ongoing decrease in that delay. But again, as I've said earlier, there's always more work to do, because it's sitting around 18 to 20% of our women are delayed during that process at the moment. And we want to get it as low as we possibly. We'll never have no delays, because we have to, as you say, there isn't any, you can't not come into the hospital if you want to have a baby. We can't delay that because it's time critical, and we have to work within the confines of that. So, but we want to drive that down to a much lower number.
Thank you very much indeed. Sorry, my apologies. Councillor Turner was next. His name's on the list and I overlooked you.
Yeah, thanks very much indeed, Chair. We haven't mentioned at all about caesarean births, and obviously that's a concern of mine, being a father of 3 daughters, and now they are starting to have their own family. And I'm just wondering, with the caesarean sections, is this more to do with the safety of the unborn child, or is it more risk averse as far as the medical profession is concerned? Obviously, I'm concerned about the welfare of my daughters as well as any unborn child, and I believe that if you've had a caesarean on your first child, then you will have a caesarean on your second child. Is that correct in thinking that? Well, from conversations I've had, we've already mentioned earlier on about the ageing population we have, and the birth rate is fallen to about 1.41, I believe, per mother. The replacement should be over 2, and obviously with parents-to-be, mothers-to-be, with this increase in caesarean sections, then this is not an actual thing that's going to encourage potential mothers to have children when they're frightened by the potential medical intervention if they do have children of their own. And I just wondered, those sort of things are connected, in my opinion. I wonder if you can give me any answers on why you feel caesarean sections are raised over recent years, where probably years ago they weren't so popular. I wonder if you can explain a little bit more about that for me, please.
I can, yes. So nationally, the caesarean section rate has continued to rise, and locally we reflect that within our own figures. I think there's a lot of things in play here. So just first of all, if you have a caesarean section with any of your children, you don't necessarily need a caesarean section the next time. It takes careful counselling, careful decisions to be made around how that pregnancy and that birth will be managed the next time, absolutely. And there are increased risks associated with having a vaginal birth following a previous caesarean section, but it's not to say that that's not possible, and lots of women do go on to have that, but that has to be their choice, and we have to give women information so that they can make that choice. and decide whether they want to take the risks, as well as the benefits of not having a repeat caesarean section. I think there's an awful lot in the media and in social media around fear in childbirth, and I don't think that's always particularly helpful in helping mums to make decisions about how they want to give birth. We've seen an increase in number of women choose to have a caesarean section with their first pregnancy, and that's their choice to do that as long as they understand the risks as well as the benefits of that. And I think a lot of that is driven by an awful lot of misinformation out there, and we have to do better at trying to counteract some of the mistruths that you see particularly within social media. And the sources of that information are not always reliable. So there's a lot of work to do in that space, but fundamentally it does boil down to the family's choice, making an informed choice about how they want to have their baby, where they want to have their baby, and via which route they want to have their baby. And that's what we're focused on doing at the moment, is making sure that we're having those informed conversations so that families do truly understand the risks as well as the benefits of the choices that they make.
I'll just follow on, yeah. I know potentially with, say, a caesarean, you can have pockets then occur after caesarean, which will potentially, specialists will say, well, those pockets will need to be, have an operation or something in order to rectify those before considering a further pregnancy. So that would be an issue. Again, it's all to do with encouraging women feel as if they're safe. I understand what you say, it's all to do with knowledge and risk averse and so on. But when you have all of this data to mothers to be thrown at them, you are going to try and take the line of less resistance. So then that would ultimately, as you say, a mother to be perfectly fit, no issues, opting to have a caesarean birth. It seems really quite strange to me that they choose that pathway, and it just that really needs addressing as far as I'm concerned. If you're perfectly fit, no issues at all, why shouldn't you be giving birth naturally?
I think it is choice, though.
It's choice. Yeah, it has to come back to choice.
So, you know, it's about an informed choice. So whichever way you choose to have your baby, if that's vaginally or surgically, it is your choice. As well, as long as the woman is well aware of what those implications are, the risk to themselves, the risk to their unborn baby, it is absolutely choice. And the whole 2 independent reviews from Donna Rockenden at Shrewsbury and Telford all centred on choice. And that's what we've got to be grounded in. It is the woman's choice, and we need to support them with that choice.
Thank you very much. Councillor Ward, are you coming in on this point?
Yes.
Okay.
Yes, thank you. I agree with the choice aspect to that entirely. It might also not be a choice if you have a multiple pregnancy, like a twins or triplets, where the risk to subsequent children in the womb might outweigh vaginal delivery. So you may have to have a caesarean operation. Once you've had one of those, following births might be more problematical. So,
and that's the information that's given.
It is not just singletons. It could be.
Absolutely. And that's the information that's given through, I mean, I'm not a midwife. I sound like I am, but I am not. So I'm a nurse. But in terms of being a mom who's had 2 babies, who both had sections, you know, it is about that choice.
Yes. Or not, as the case may be.
Yes.
Or not. Yeah,
Absolutely.
Sometimes it's recommended,
Yes,
because,
it
as
is.
you say, of the the more complex pregnancies. But again, we can never make somebody do something.
No.
That is not what we're here to do. The choices are there to be made, and as long as we're satisfied that families have had all of the information to make an informed choice, then we've done our job properly.
And we know that we have women whose choices they make are against medical guidance.
Mm-hmm.
We know that. However, these women have got capacity, and therefore we have to support where we can. but not everybody will follow guidance, will they, Justine?
Okay, we have a large number of men wanting to come in on this conversation. She's really interesting, isn't it? Councillor Harrison, I haven't forgotten you. I think the two gentlemen that have raised their hands now, is this connected with the continuing conversation? Right, so I've got Councillor Taylor and Councillor Turner.
Very male question, this.
Come on, I'm coming back to you, Councillor Wild.
A very male question. Why would a woman choose to have surgery instead of having a natural childbirth?
It's vaginal childbirth, not natural.
Oh my goodness. We could talk about that for a very long time.
Yeah, we could. And you also don't know what that woman's going through. You don't know the position of that baby. So, for instance, 20 years ago, my little girl was an extended breech, and I was counselled and given advice about what do I want to do. My choice was I will go for a caesarean section, which 20 years ago wasn't particularly that popular because I had all that right information.
Sorry, but you just said people choosing it if they're not recommended it. You're saying before they're even recommended.
What I said is that people choose to do lots of things that's not always against guidance, not just about sections. It's very unlikely, I'd imagine, that someone is recommended not to have a section, just if they chose. Are you
talking about mums where things are very straightforward and they say,
why?
I don't want to go through trauma, previous life trauma, fear. There's a recognised condition called tocophobia where women are fearful of childbirth. Vaginal birth is not without risk, and I think we just need to be really clear about that. Even if you're a fit, healthy mum with a very straightforward pregnancy and a well-grown baby, there are still risks to having vaginal birth. So I think, I could talk to you probably for about the next 2 hours about maternal choice caesarean section, counselling, risks and benefits discussions, etc. But we don't have that time. But women make that choice for very, very individual reasons. It's not kind of like there's a group of women over here who will always do this. It's very, very varied and very, very individualised.
Thank you very much. I've got Councillor Harrison, then Councillor Wild, please.
Thank you, Chairman. On a much less painful subject. I understand why you're doing work to reduce women with smoking, obesity, vaccinations and whatnot, because I presume that as I understand it, smoking, for example, reduces birth weight, I understand. But what effect do these programmes have on either healthy births or healthy babies, please?
So the fewer mums that smoke, the better grown babies we have, and they will be born with a better birth weight. And obviously therefore healthier at their start in life. In terms of vaccinations, it's generally if you give a woman a vaccination, she then obviously has that protection but passes on some of that protection to her baby. So in those early months and years, they've already got some protection when they're born, particularly, and we've seen some evidence since we've introduced RSV, that vaccination, that there has been a massive decrease in the number of young infants being admitted to hospital with RSV. So that's been really successful, and that's only been in place for about, I'm just looking at Claire now, 12 months-ish. So we're seeing some really good outcome data for that vaccination.
Thank you very much. I think if I just come in at this point, Public Health are here with Claire Mitchell and Dr. Lisa McNally. Good morning, both. I think it's your opportunity now just to give a brief outline of what you've been doing in the preventative arena, please.
Is there a particular topic you wanted to focus
Well, around
on?
stopping smoking in pregnancy, obesity, the prevention, the preconception conversations that we know are happening at family hubs, etc. I think anybody watching this down the camera will be thinking, well, what's Public Health doing? And I just want to give you the opportunity to contribute.
Yeah, no problem. I'd say smoking and maternal obesity are probably the two areas that we focused on a lot over the last couple of years. As we've mentioned in the report that was added in, we've had a huge reduction over the last few years in smokers at time of delivery. As you mentioned, Justine, the smokers at time of booking are coming down as well, which hopefully is potentially impacted by the fact that we're doing a lot of postnatal work with our smoking services. In the first few years, we had a maternity smoking service within our maternity teams, but over the last couple of years, we've also embedded that into our health visiting offer, so that we know that a lot of people, even though they have quit smoking in pregnancy, can also relapse in the first few weeks after birth. So the postnatal loop, bringing people back into their next pregnancy, hopefully as non-smokers, we're hoping is also added to that smoking rate coming down. As Justine put in the report, our smoking rate at time of delivery now is down at 4% for this year, which is, we had a huge drop from the previous year to last year from 8 to 6, so to go to 4 is really positive. And also maternal obesity is something we're trying to focus on a lot more going forward. So there was a Blooming Healthy pilot, as Justine mentioned, which has been starting to see people over the last few years to support a healthy pregnancy, to either maintain or in some cases reduce their weight in pregnancy. We had quite a small capacity to do that because the public health midwives that we were supporting to be working within the trust had quite a few work areas that they were pushing forward. So to be able to add some more dedicated capacity into maternal lifestyle, we're just starting that pilot now to look at how it can link with our smoking services and maternity as well, because we know a lot of the women that are smoking in pregnancy are also overweight. So if we can look at a service that combines those two, so we're not passing from pillar to post for different support options, we're looking to see the impact of that. And a question not long ago was asking about the benefits within birth and the wider benefits. There's so many benefits to reducing maternal weight in pregnancy. So with this pilot, we're also looking to not just look at the outcomes of the intervention that's being delivered in terms of their mental well-being and their diet and physical activity, which we know have really positive benefits. We're also looking in this next pilot to be able to dig into the data in terms of the impact on birth outcomes, the impact on early postnatal indicators as well, because we know anecdotally a lot of the women that were receiving lifestyle support in pregnancy also went on to make better choices with their lifestyle postnatally, because they'd had that boost in pregnancy to be able to make positive choices. So they went into those first few weeks and months as a new parent with a kind of boost with their own well-being. So also looking at infant feeding choices as well, and how that can be impacted by the pilot.
Thank you very much, Claire. One quick question. Have any studies been carried out on the impact of vaping whilst pregnant? Was it? We know that vaping during pregnancy is considerably more healthy than smoking in pregnancy. We know that vaping within our smoking services has dramatically also reduced our women that are smoking in pregnancy. So we know it has a really positive impact on quit rates, and we know that has obviously a huge impact linked to it. It's still a developing area in terms of the research, but we know that there's a huge benefit to people reducing from cigarette smoking in pregnancy. And with all the services that we support women with in our smoking cessation offer, we also support them to come off vapes as well. So vaping is only ever an aid to quit. We would never ever support women to vape in pregnancy if it wasn't a short-term aid to support them coming off cigarette smoke. Thank you, Claire. And just before I move to the final few people that are going to ask some questions, Public Health are supporting the introduction of lifestyle coaches. How are we getting that message out, and where will these lifestyle coaches be operational from, please?
So these will be the maternal obesity. That's the pilot that we are expanding from Blooming Healthy. So is that the term you're using? I hadn't looked at what the posts are going to be called yet. So this is the Blooming Healthy expansion. So previously we had one public health midwife that was running the clinics at Band 7, and there was the recognition there was a lot more demand for the service than that public health midwife could offer. And also, as Justine mentioned, the outcomes were really positive. So the lifestyle coaches are going to be an expansion on that Blooming Healthy pilot. They're going to be working closely with the Stop Smoking advisors and potentially delivering kind of cross care if there are women that are smoking and struggling with their weight and lifestyle. So they will be embedded within the maternity teams, like the smoking advisors, but also, as with a lot of the maternity offer, particularly the public health funded services, we like to expand that into our community locations as well, so families can access support in family hubs and in community settings. So the public health midwife that was delivering the lifestyle pilot was delivering it from family hubs, as well as in the maternity clinic setting, so we can make that more accessible for families.
Thank you. One final question from me before I hand over. I've just got a question around preconception. How do we educate people to be healthy before they fall pregnant? Because it really is the best prevention out there, as we all know.
Preconception is always a tricky one because sometimes a lot of people don't know they're going to have a baby before they do. So we've got a group of women that are looking to and planning to have a baby. So preconception care is often a lot easier in that space. So we can work with services that are more likely to be coming across women of childbearing age, and also dads. We want to ensure that fathers-to-be are also supported with preconception care, because there's obviously a lot of benefits to mothers and fathers being able to prepare their bodies and their self and their life for a new baby. So there are a lot of avenues in which we can support maybe families that are preparing to become pregnant through different ways of targeting, and also there'll be a preconception route through people that have already had children before. So we've worked with family hubs and health visitors and our range of community support offers. People that are looking to have subsequent pregnancies, we can look at putting support in place. But in terms of families that don't know they're going to become pregnant or haven't plans, that's where it comes to just looking at population health, in terms of ensuring that our population is healthy as they can be if they're not planning to become pregnant, making sure that they are fit and healthy and have the best preparation in place.
Thank you very much, Claire, and thank you for taking us through the work of public health on this matter. So I have now Councillor Wilde, please.
I hope my question's worth waiting for. I've had 3 babies. Second birth was the most difficult, which was interesting that you said it can be easier, so it's not always the case. And it can be complicated because the baby can have infections. So I've been through that. But one of the things that we've not really discussed is mothers who have miscarriages and your services for them, because I know it's there's a lot of awareness about this now. When I've had 4 miscarriages and there was absolutely no treatment, you just get on with it, fact of life. But I know it can be deeply distressing. So I was wondering what services you do for them, but also I'm going to sneakily shout out for Malvern whether or not there are plans to use our community hospital for your extra services rather than dashing down to Worcester when the time comes. So I was just wondering if you could address those 2 issues, please. Thank you.
So, for ladies who miscarry, they generally are cared for by our gynaecology team. So it's not my area of expertise, but obviously I'm aware of the service. We have early pregnancy units in each of our hubs, as well as based at the Worcester site. So some early pregnancy care can be provided in those areas. Obviously, if women then go on to miscarry and need medical treatment, they'll be cared for at the Worcester site. And in terms of support, there are a lot of support networks, as well as a support run by the gynaecology team as well, particularly for those women who have recurrent miscarriage, because that can be incredibly challenging. And there's a very clear pathway of care and support for them. We also have a fairly new service. It's probably not as resourced as we'd want it to be, but at least we have it, not everybody does, called maternal mental health services. And women, again, who have had recurrent miscarriage and challenges with fertility can be supported by the maternal mental health service. But as I say, it is only a small service. And hopefully over time we'd really like to grow that service so that it's more sustainable and more available to others. So I'm probably not the right person to ask about the details of the miscarriage service, but that's some of the overview of what we provide.
If you'd like some further details, we can always come back to you, Councillor May, if that's what you'd like.
That'd be great, please. It's about raising awareness, isn't it? If somebody sadly goes through it, where do they go for some support? And it's a really pertinent question, Councillor Wilde. Yeah. Thank you. Councillor McSweeney, has you got a question, please?
Not working on. Thank you. Thank you, Chair. Yes, I did have a question. I was just going to comment on something earlier about sort of the caesarean section. I'm sorry, it's social media. I did read something very recent on social media saying that, commenting on sort of a child that had been starved of oxygen during birth, that had a caesarean recommended, and the mother had chosen to have a natural birth, and so obviously there's clinical reasons going in that direction as well. I thought I'd throw that in as an anecdote. But my question is on the vaccine uptakes. I mean, the sort of numbers we've got here, they look kind of lowish to me. I mean, what would we like to see as vaccine uptake numbers, and what can we do to improve it?
Could you put your mic on, please, Claire? Sorry.
Yes, I haven't worked directly on vaccines. That would be our health protection team, so I don't know if...
Dr McNally, thank you, Claire.
Yeah, so we're always trying to push vaccine rates up. And I was on a meeting this morning, actually, a conference meeting where we were hearing about how all areas around the country are struggling to get vaccine uptake rates back up. But certainly our rates in Worcestershire are among the highest in the region, and in some measures in the UK. I think that we just need to keep offering a holistic conversation with women, whether as soon as they become pregnant or in the later stages, about all the things they can do to improve not only their health but their baby's health, and vaccination is absolutely part of that. As you've all demonstrated, actually, there's a lot of information on social media about being pregnant, and it's not just you guys reading it, it's the women themselves as well and their families. I was once told by a mum who was pregnant that she'd been advised by her family not to quit smoking because that would be more stressful and more harmful for the baby. So women are surrounded by a load of old rubbish on social media, and a lot of that, as you know, pertains to vaccines as well. But the advice is clear. If you're recommended to have a vaccine, take it. Stop smoking. Lose weight if you need to, and keep yourself healthy and prepare for being a mum.
Thank you very much indeed. So I've got two final questions, one from Councillor Nick Price and one from Councillor Sue Eacott, please.
Thank you, Chair. Today we've heard a lot about maternity services and how the system is meant to work, but I just wanted to say something briefly, not as a councillor but as a father myself. When my wife gave birth to our son, we were at home and things didn't go to plan. It was one of those moments where everything suddenly feels uncertain. And then the paramedics arrived. They were calm, reassuring and completely in control. They made a difficult situation feel safe, and they helped bring my son into the world. You don't forget that. So while this report today focuses on maternity services, I just wanted to recognise the role of our paramedics play for when things don't go as expected. Because of my family and many families across our county, they do make a real difference. So thank you.
Thank you very much indeed. A really pertinent point too. Our paramedics are our heroes, are our angels that come and support us before we get to the services we actually require. I'm glad things worked out well for you and your family. Councillor Eacott, and I've also got Councillor Tom Wells who's gesticulating at me. Thank you.
Thank you, Chair. And thank you. I've got 3 granddaughters. One was born breech, They didn't find out till the last minute, so she came out feet first. And the other one was born just over 30 weeks. Both were born in the Alex, which at the time maternity was a wonderful place. And there was only one incubator in there, which my granddaughter had. And then after she was taken out, she was put into a hot cot or a warm cot. My question is, if babies are born at home and then it's suddenly found one is breech, how do the midwives cope with that? Because my granddaughter had to have a team come in to her. She was born naturally, she wasn't cesarean, but it was very touch and go at the time. And I think having a lot of young mothers now out there who are not aware of what could happen, and especially ones being advised to have their babies at home, I think there should be more awareness of it out there. Thank you.
So in terms of breech birth, you don't see an awful lot of breech births anymore, which is because most of them, well, a good proportion, around 80%, are actually identified during pregnancy. So then plans are made, and those conversations that we talked about earlier are undertaken so that women can make an informed decision about what they want to do. There are a number that are undiagnosed until well into labour, and sometimes at the the advanced stages of labour. But midwives are trained to deal with it. I'm not saying that it's something that they do all the time, but we do skills drills every year. The community staff do more of them. Particularly, if you recall me talking about the home births now being done by a much smaller team of midwives, so we can do focused regular drills with those midwives more frequently, just to deal with that sort of unexpected incident that you're talking about, so that we can deliver breech births at home should they arise in an emergency. But we would never want to plan to do that. Some of our mums will choose, as Hayley referred to earlier, sometimes mums will choose to do things that we may not feel is the right thing to do, but with the advice and guidance and those conversations around the risks and benefits, some will still choose to do that, and then we'll do some really regular drills and regular support for those staff who are going into that home to look after that woman, or if we already know that it's going to happen.
Just going back to your point about there's a lot of decisions to make, and that's why it's so important that when we talk about midwives, it's the midwives throughout the whole of that woman's journey. Mm-hmm. So it's about having that continuity of care, for example, is having that really good relationship with your midwife. So you aren't just asked a question once, you're not just risk assessed once. It's a continuum throughout the whole of your pregnancy, because then you can make decisions that are right at that time, and they're constantly reviewed. But you're absolutely right, there's a lot of information out there. So it's making sure that information is understandable, and also it's that relationship between the midwife and the woman is really important.
Thank you very much indeed. The very last two questions now. I've got Councillor Wells and Councillor Turner, please.
Okay, so on page 3, the diagram at the top providing driver scoring summary, I can't read. Now, either I need to go to my optician and get a better set of glasses, or we need to do something that actually increases the print so I can read it. But my question really relates to that, and relates specifically to ethnicity. Now, a quick Google tells me that infant mortality rates are significantly higher for Black and Asian ethnic groups compared with white groups. Is that something you experience at your end of the spectrum, and in terms of the first 100 days? Do you see any evidence of that, or anecdotal evidence of that? And just the other final question is it the case that we've kind of, as in the UK, plateaued at the number of deaths per 1,000 in the first 100 days? Do you recognise that stat, and is it replicated in Worcestershire?
Yeah, I can come in after and talk about inequalities.
Okay, so in terms of inequalities from an ethnicity perspective, We do see still some poorer outcomes for those families. Obviously, the demographic in Worcestershire is very different to other parts of the UK, and we have a very an over 94% white population of pregnant women within our that access our services. So absolutely right, we do see some differences in data, but it takes an awful long time to see it. You won't see it within a year because of the numbers of babies. They're still quite small. I think you're absolutely right that some of the neonatal death rates have seemed to plateau, but the stillbirth rates have continued to drop, and the brain injury data also for babies in labour has also continued to drop. So there's some work still to do in the neonatal death space, but there's some really good improvements in other parts of the service. But I think, yeah, we're plateauing a little bit nationally and probably locally as well.
Thank you very much indeed. Councillor, Claire Mitchell, you want to come in?
As you mentioned, there are inequalities throughout many outcomes linked to Best Start in Life and maternity care. The recent Best Start in Life strategic plan that was published a month or so ago outlines our system approach to ensuring that we have improved outcomes throughout the first 1,001 days, but also the first few years. And we take quite a population approach when we're looking at our inequalities across our services. So there are lots of different work areas within our Best Start strategy that we dig into the inequalities in terms of the data to be able to understand which communities are more likely to achieve poor outcomes, so we can take a preventative approach and ensure that we are picking up any poor outcomes early. So, for example, I know our maternity services have an approach looking at inequalities within their dashboard. We also dig into our service data and outcome data with our smoking services, for example, to look at inequalities, so which services, which families and individuals and populations are more likely to be smokers, for example, which groups are more likely to accept a referral, quit and maintain their quit. We look at inequalities in our health visitor data across the board, in addition to, as we mentioned, our maternity data. So we're really keen to understand what our inequalities are so we can target services and shape services. So if we know there are certain geographies or certain ethnicities or community groups that are more or less likely to access services that are more likely to support the kind of end birth outcomes, then we do a lot of work across the system to target that. So to look at where our family hubs are, where our smoking service clinics might be. When the MNVP do engagement to understand with families what their outcomes have been and what their experiences have been of maternity care. I know there's a huge focus within that co-production and engagement work to target harder to reach groups and to target communities that are potentially experiencing poor outcomes. So we know at the moment, for example, there's a huge focus on our GRT communities to really understand what the barriers might be to their care and support, because we know that they can experience poor outcomes as well. GRT, Gypsy Roma Traveller communities.
Thank you.
So there's a lot of preventative and early intervention focus on inequalities. We know there are poor outcomes in some areas, and that's nationally, but we do a lot of work in Worcestershire to understand and ensure we're shaping and targeting our services to reduce those inequalities.
Thank you very much indeed. The very last question, Councillor Turner, please.
Yeah, earlier I mentioned about caesareans and so on, and you quite rightly said that it's the choice of the mother, and that's absolutely right and should be absolutely paramount. But giving them the right information so they can make those informed choices is very important indeed. And certainly what's already been mentioned about myths are being put about on social media that misinforms parents-to-be. We've mentioned lifestyle coaching, so where they're able to get this factual information from. And I know from my own daughter's experience, they've joined NCT groups, the National Childbirth Trust. And because I think it's important that mothers-to-be can start learning from each other, because shared knowledge is very important, because otherwise you just get sort of this fact sheet put in front of you and it can be totally bombarding. So I think certainly this lifestyle coaching is very important, and that's what we should be pushing more and more. Thank you.
Thank you very much. I think everybody agrees with that. Dr. McNally just indicated she'd like to speak, please.
Yeah, I'm going to try and not go through a HOSC meeting without mentioning this point, because we quite rightly talk about all the clinical factors, the health service factors, etc. But let's remember the biggest determinant of poor health in children, infant mortality, is poverty. And the number of children living in poverty in Worcestershire is rising. So I wouldn't ever, as a DPH, I always sort of need to, like 175 years of directors of public health before me, always raise those social conditions in which people are living, and how the single best thing we can do is do what we can as a society to reduce the number of children living in poverty, and indeed the number of pregnant mums. And secondly, to invest in our communities, because we've lost, haven't we, to some extent, the old ethos of it takes a village to raise a child. And what we've seen in Worcestershire is the support that can be offered to women, pregnant women, to families, and to young children as they grow from communities. So I think addressing poverty, increasing investment in our communities, will have a big effect on every single bar chart in that paper if we put our minds to it. It's not easy, but I just didn't want us to lose sight of that while we talk about all these clinical factors.
Thank you very much, Dr. McNally. A really pertinent point. As we know, it's the wider determinants of health, isn't it? The situation you're born into and your life progression. Justine, Hayley, thank you very much this morning for your attendance. I'm just going to go through the 3 points that have been raised in my own mind with the support of Mrs. Morris here. So following this, the home birth study to committee, please, with the prevention of future deaths report. That's Jennifer Carhill. And then information on miscarriage service and Baroness Amos's independent investigation into maternity and neonatal service report. When it's into the public domain, could you send us a link, please, as a committee? Thank you so much, and thank you for all you do for the expectant mums and expectant parents, actually, of people that live in Worcestershire. It's very much appreciated. Thank you. We'll now change over to the next subject matter, which is cancer pathways, and we have the team from the Worcester Acute Hospital Trust here. Thank you. Thank you very much indeed. Good morning, Murray, and good morning, Chris Douglas from the Worcester Acute Hospital Trust. Very grateful for your attendance this morning. I'll hand straight over to you, Murray.
Okay, thank you. Good morning to you all, and good to see you all again. So we're going to do this presentation jointly. I'm going to give the overview of the cancer pathway for Worcestershire, some of the prevention and early diagnosis that we are improving in our system, and then Chris will talk you through some of the performance from a trust point of view on the actual cancer waiting times and the treatment times in the hospitals. Okay, so this is this report's an update on when we came in October 2024 on that cancer pathway, but it's got a particular focus on early diagnosis and screening for cancer, and then obviously the waiting times. And we are guided a lot nationally by the National Cancer Plan, and that was updated in February this year. And best practice cancer pathways nationally, we're heavily influenced by those. And it's pleasing to say that national plan is aligned to the work that we're already doing in our local cancer strategies and plan. It's got a little more focus on personalised care for individuals, with cancer. Whilst we spent many years getting the cancer pathways right, the best practice cancer pathways, we know we need to make them as personalised as we can to individuals. And then it's got a real focus on improvements in survival rates for the population, with a target of by 2035. You can see in the paper some of the targets that we want to see nationally, about at 5 years survival rates improving. And a lot of that is about early identification and early diagnosis of cancer, because obviously the earlier you can identify someone has a cancer in their body, we can treat it earlier and get those survival rates improved. So we aim to get our cancer stages 1 and 2, that's those early stages. We aim by 2028 to have 75% of cancers diagnosed in those early stages. We are in around mid 55%, so is everyone else nationally. We're no different anywhere nationally. So the work that we're doing is really important to help to get us up to that 75%. So we encourage the public through all the social media. We've talked a lot today about the comms campaigns across all of our services to get to their GP early if they've got any concerns, as well as giving them preventative advice on diet, lifestyle, all the things we just talked about for pregnant mothers or people who are tending to have children. It's the same general prevention advice, but if they have got symptoms of any sort, we encourage very early getting to your GP, and we have contracts with our GPs to help them to get patients into the cancer pathways early to get the diagnostic they need. So I'd just like to take you through a few examples of some of the early identification that we're doing to help the population access services earlier. And this one is early identification of bowel cancer. And for those I was a nurse for many years, I nursed many patients with bowel cancer, often coming late to primary care because of sometimes the embarrassment of the public of saying I've got a problem in my bowel tract. So we are encouraging through something called Fit at 80, which we've had in place for over a year now in Hereford and Worcestershire. And it's where we do that, we encourage the population, and I'm sure people in this room have had the kits through from the national team to their home. But what we're doing nationally is in this programme, we've reduced the identification rate of blood in stools. So it's a much lower rate, much smaller rate, and we reduced the age to over 50 as well. And you can see pleasingly from the report that we, from 2018, when we had 37% diagnosis rate in stage 1 and 2, we're now at 69% being diagnosed at stage 1 and 2 for bowel cancer. And obviously the treatment is far more successful at that stage, and the intervention is far less traumatic for the individual as well. And it's great because even though we've had many more referrals through this, the Trust have kept up with the pace of the work, and they've put in the extra diagnostics and the extra workforce to manage this. So it's a really positive outcome, Fit at 80. And we look forward to the next few years to see what, when it's really embedded, what it can continue to achieve. And then in primary care and our primary care networks, we have what we call cancer collaboratives now at that level. And this is again to optimise that early cancer diagnosis through the directly enhanced services we have with primary care. But the forum gives primary care networks and ourselves in the ICB and some of the charities and voluntary sectors that work aligned to the primary care networks now opportunity to share best practice of what we're doing across Worcestershire in prevention and early identification, and to address some of the health inequalities that we see. And it's been really, really helpful as part of this work that we've now got an interactive map, which I've seen myself, which is very, very informative, of the late stage cancer diagnosis rates at local level, which parts of Worcestershire County are having those late diagnosis. And as a result, Worcester City and Redditch are planning specific patient engagement events on symptoms of lung cancer, because in those areas we know we have a slightly higher rate of lung cancer at a late stage. So we're really able to focus the work in the areas that need it, and use the the communication strategy, the social media to get that message out, as well as the national work on early identification as well. And the last example I'd just like to give you is pancreatic cancer, early case finding in pancreatic cancer. Pancreatic cancer is one of the most difficult to treat, and many of us in the NHS have seen very late stage presentation. That's part of its progress. So we are working to try and get the word out again about what the early signs and symptoms are of pancreatic cancer. And we've now gone on to have a position where anyone over the age of 60 who's got new onset diabetes or unexplained weight loss in the early days will go straight for an urgent CT. Now that pathway is different. It used to be you had to go through several stages of a pathway to get to that, and often that had a detrimental effect. It's never going to be a cancer that will be easily rectified, but at least we're trying to get to those individuals sooner. So that's 3 examples of a suite of services we've already got in place for early identification. And our next stage in the next couple of years is we're going to be implementing the lung cancer screening programme. It's a cancer programme that does, again, early diagnosis of lung cancer in high-risk populations. So people over 55 to 74 that are smokers will be assessed and invited for screening, and that will actually start by the end of March next year. We'll have that in place. We would like to have done it sooner. There is a workforce issue across the country on this that we're all tackling with, but that will be in place. And we just started it in Herefordshire, so we'll be able to share the learning as well. And then what we're putting in place this year at the end of June, actually, which is not far away now, a non-specific symptoms pathway. There are a small amount of patients in the community who have non-specific, they don't fit into a neat cancer pathway, but they've come back usually quite frequently to the GPs with non-specific symptoms. So we'll have a pathway in place dedicated to them that gives them the full range of diagnostics, again to try and intervene earlier into their potential cancer journey. And I'd just like to give you a bit of an update on the screening programmes. We do fairly well on screening. We have good screening percentage rates for the general screening for cancer in our community. But we're trying to target some of that this year going forward. Some for cervical screening, because since the pandemic that has fallen off. Breast cancer screening has come back up, which is really pleasing to see. But cervical screening nationally, and we're seeing the same, is not as robust as it was pre-COVID. So lots of thoughts as to why that is. We're doing a communications campaign to help. But we're trying to target individual groups as well. So you'll see 2 examples in the paper of the LGBTQ+ programme around cervical screening. And we've really worked with our partners in primary care to get the message across. That service is still available. It's available to you. Please access that service. And then we've obviously got a female seasonal workforce in our county, and breast screening is low in those areas. So we're doing some target engagement with those seasonal workers to make sure that they have access to our breast screening programs as well. So it's helpful now to have those have good overall screening, because we can focus down in the areas of need. The big risks we have from what I've just talked about is those national workforce constraints, particularly in breast screening. That is a national workforce issue that we're trying to, again, grow our own locally and make sure we get people into the training programs to support this, and maintaining the growth in demand for screening, for early intervention. It's, the workforce needs to almost shift into that work, as well as being able to respond when a cancer is diagnosed as well. So largely, there's been great. I was thinking back, preparing for this. In the last 5 years, the world has changed really in screening and early identification of cancer. We now need to, with the growing population, and particularly the growing elderly population and diversity of population, we need to make sure that we continue to grow those services to meet that demand going forwards. Okay.
Thank you very much. Before I hand over to Chris, just one quick question. When you speak about the issues around lung cancer, for example, in Redditch and Worcester, are we linking in with the Healthy Worcestershire bus? Because we get the bus into areas where people don't naturally go to the GP, etc. So it's an opportunity for messaging, isn't it? Dr. McNally.
Yes, so in those areas, I mean, Redditch, our community development work is probably equal to the rest of the county at the moment, our investment in that. So we're running all sorts of events, working with the voluntary sector to raise awareness of all of these programmes, everything from screening to smoking cessation. And, you know, we've seen some success in that. As you know, our smoking rates dropped by 1/3 last year. I couldn't believe it. I was going to, I'll take it. It's great. But, you know, we're getting the message out there. And as Mary said, it's all about focusing in on those pockets of low uptake, often deprivation, that we need to, is the last piece in the jigsaw to get our figures up as high as they possibly could be. So absolutely, there's a lot going on in those targeted areas.
Thank you very much indeed. Back to you, please, Chris, and welcome.
Thank you. So I'll just take you through some of the cancer diagnosis and treatment elements from an acute trust point of view. So we are continue to see an increase in referrals. So now, as the paper says, about 2,900 referrals a month. We're treating about 330 patients for their primary cancer a month. So in terms of the numbers of cancers we're finding, the percentage is broadly staying the same, but we are seeing more and more in those earlier stage cancer treatments, which is positive. The other good news is some of the improvements we're seeing in how quickly we are telling people who are referred to the organisation that they have or they haven't got cancer. So it's important for both elements of that. So clearly for people who haven't got cancer, letting them know and reassuring them is really important. And when patients have got cancer, letting them know more rapidly so that we can get on and support them through the treatment path and what it means for them and their families. Again, remains really important to us. It's not without its challenges though. So whilst there have been some improvements for the overall population, there are some particular challenges in some specialty areas that we've set out in the paper. We are doing more overall in terms of what we're creating capacity for diagnostics, in terms of expanding some of that diagnostic capacity, because we see more and more now reliance on imaging, pathology and other elements such as that to inform diagnoses. And the work that we're working across the county around establishing an additional community diagnostic centre will not only help to transform cancer diagnosis, but also wider access to diagnosis closer to home, which is also really important for all of our patients. Some people may have heard about PET-CT, which is a specific type of CT scan that we do not currently have facilities for locally, and patients either have to travel to Birmingham or to Cheltenham. So we are in conversations with a supplier about potential provision of that within the county, which will again reduce some of that travel time for patients. And ultimately we need to do more with our partners in the tertiary services, both in terms of diagnosis and in terms of treating patients. So if I touch on the particular specialties of challenge, many here will have heard previously in terms of previous updates about the skin cancer pathway and this dermatology service. As you'll see in the paper now, we've made some strides forward in terms of recruiting some of our own staff to support that, to deliver that service, with ongoing support from a strategic partner. But we've also introduced teledermatology, meaning that people can have their photographs taken more locally, so we can make more diagnosis, which is it's new to Worcestershire, but it's certainly not new to the world of dermatology in terms of how we can support patients to understand what that means for them more rapidly. And also the establishment of one-stop clinics so people can come, have their diagnosis and, where appropriate, their treatment in the same day, meaning less visits to hospital. If I touch briefly on urology next, urology again has been talked about as a service with significant challenges, I suppose. We continue to see an increase in referrals, both because of the right public health messaging, but also there are been a lot of high-profile people with urological cancers in the press, which has driven up referral rates. So we are taking some short-term actions around short-term capacity that we can put in place, but there's a longer-term piece of work we know we are doing at the moment around what we need in terms of the underlying capacity, but also how that service is delivered in terms of how we make more of the wider healthcare professional group to deliver that service, and how we expand our robotic capabilities on the Alexandra site for robotic surgery for treatment. At the moment, colleagues will know that we've got one robot, and the aspiration is certainly that we'll need to increase that as we meet the demands, not just for urology cancer, but also for wider other services that use robots to deliver their surgery. If I move on to breast briefly then, so again, breast has been one of those services that has historically delivered well for patients in Worcestershire, but has seen a significant increase in referrals, and whilst we have some stability in the team, there is some challenges around some workforce in that area, and we're working with colleagues across the wider piece in terms of what that looks like. We have introduced a new breast pain pathway in collaboration with the primary care colleagues for those with what's deemed low risk breast pain, ensuring that those with the low risk symptoms are assessed appropriately and those with high risk symptoms are able to access services more quickly. And then lastly, lung cancer clearly is a significant priority for us for all the reasons that we have just talked about, but it's also one of the most complex in terms of diagnosis. But we also know that for lung cancer, every day really does matter. So in terms of the improvements that we know we need to make and working with our team around increasing capacity, we rely heavily on external diagnostics, specialist diagnostics at Birmingham, and also a lot of the surgical treatment isn't done locally, but elements of the pathway in terms of radiotherapy challenges and the capacity we need in terms of creating that and working with the workforce in terms of the deep dive with the Cancer Alliance. I'm conscious I'm still going, and there's lots of other really interesting stuff happening. We have been fortunate enough to have some money from the West Midlands Cancer Alliance that is enabling us to pump prime a number of schemes across a number of those specialties that will enable us to evaluate the impact it does have on our patients and on our services in terms of what that means for the future in terms of sustainability. And then just briefly, the big bit on here about living with and beyond cancer is also really important to us as an organisation, because telling somebody they've got cancer and treating their first bit of their cancer or the first treatment for their cancer is really important, clearly, but actually supporting patients who have lived with and are continue to live with cancer throughout the rest of their journey is really important in terms of what we can do, how we can work together. Part of this is about what we need to do in terms of stratifying follow-ups, so meaning that patients only return and have follow-ups where they really need to, and giving patients more control over what those follow-ups look like and when those happen for them, recognising there are some guidelines that we need to continue to work within. And how do we enable patients with cancer or living with cancer and beyond cancer to support each other through facilitating wellbeing events and sort of peer support groups. So not just leaving people to feel like they've got nobody there to support them, but actually how as an NHS we can support them locally, as well as working with the great cancer charities in the voluntary care sector in terms of what that means, as well as digitising elements of that, as you see the reference to the Cancer Services app. I will leave it there, Councillor. Thank you.
Thank you very much indeed, Chris, for taking us through that. And of course, there is a lot of work going on in this area for which we're most grateful. And I think at this point we need to give a shout out to the hospice movement for the work and support that they give to our patients across Worcestershire too. Questions, please. I think we're starting with Councillor Wilde, please.
Thank you, Chair. It's going to be a bit difficult for me, but first of all, can I thank you for all that you do? But I'll be focusing on the pancreatic cancer pathway. So I'd like to make a short statement, really, rather than a question, but I think questions will arise out of it. So as a counsellor and current carer, and from direct experience of the pancreatic cancer pathway within Worcestershire, I want to raise several concerns from what I'm seeing now in practice. In my experience, there appears to be a recurring situation where patients with pancreatic cancer can become very unwell quite quickly, with serious infections such as sepsis and significant functional decline. This can impact their treatment options, delay or prevent the start of planned treatment, and potentially affect survival outcomes. While individual hospital admissions are generally managed very well, what seems to be less consistently addressed is the overall pathway between admissions when patients are progressively becoming weaker and more dependent. The current cancer pathway update shows progress in several cancer types, which is very welcome. However, pancreatic cancer remains an outlier, and you've referred to that, with significantly poorer outcomes, largely due to the diagnosis often occurring at later stage. This raises questions about whether earlier recognition of symptoms and earlier clinical suspicion are being fully used so that patients can be investigated sooner and diagnosed earlier when more treatment options may be available. I say that because I've just experienced that what you've said in your report didn't actually happen. Crucially, after diagnosis, there can also be a gap in coordination where patients and carers are left to navigate follow-up investigations and seek support while waiting for results. As a carer, there was a missed opportunity to identify infection earlier in the community setting. Given the patient's vulnerability, including a urostomy, basic infection screening at an earlier stage may have identified infection sooner. There is often an expectation that patients can return home from hospital stays, but in reality, many may be too unwell, and families may not be in a position to safely provide the level of care required. This can lead to repeated crisis admissions and places significant pressure on both acute services and carers. My concern is that the pathway seems to be largely structured around individual hospital episodes in isolation, rather than reflecting how patients can decline over time and the practical realities of discharge into the community, where being at home is only safe if the right care and support are in place. Experience shared through a pancreatic cancer support group suggests there appears to be variation in how this pathway is delivered across different NHS areas. It is important that patients do not experience a postcode lottery in care, treatment and support, and that access to a consistent standard of pathway delivery is available wherever people live. To conclude, overall, this raises concern that there may be a postcode lottery in the consistency of pancreatic cancer care and support across the NHS system. I want to thank you all for listening to that, and it's been very hard to deliver.
Thank you, Christine, very much indeed. I know living with a terminal illness is really, really difficult, and I know how difficult that you and your family have found it, and our thoughts are with you. Mary, are there any words?
Thank you, and just to echo the same sentiments. Pancreatic cancer is a very difficult cancer, and you know, for the individual and their family. And if you need any support, more than happy to discuss afterwards. We can see what extra support you need, definitely. But I think, you know, one thing that I picked out from, there's two things I picked out from that, which, you know, I think we can go away and look at. If there is a postcode lottery inside Worcestershire, we need to look at that definitely. So we'd welcome any feedback from that pancreatic group from Worcestershire, and I'm sure Chris would support that. But also, you know, discharging frequent crisis admissions for anyone in this position, it does not help them or the family or anybody. And it's something we debate regularly, isn't it, Chris, about what the impact of this is. So we would like, if you would, you know, when you feel, if you can, through that group, we would like to discuss how we can support people better with the information they need to stay at home, because that is the best place for the individuals, but they do need the support wrapped around them very quickly and consistently. Because, you know, sitting in an A&E department, that's no disrespect to the A&E department, with that sort of situation and minimal interventions that will actually make a difference, it is a difficult situation. So happy to speak to you outside of the committee.
Thank you very much indeed. Councillor Tom Wells, please.
Chairman, thank you. It's quite difficult to follow that narrative just a moment ago. I want to look at page 13, the cancer standard, the comparison between 24 and 25. And just point out, as far as I understand it, just over a quarter of people who have been diagnosed do not receive any treatment within the first 2 months. It sounds to me as though there's a job still to be done there in terms of reaching the national targets. I want to also ask you about the mental health of those working through the pathway, whether they are directly the patients or the loved ones or family or friends of those involved. We all talk with personal experience, but hope, just like Christine, that we can draw on that to create a general question. And in my circumstance, and I don't suppose there's many people in the room who haven't been touched by cancer, in my experience, the journey began really with the diagnosis. Although we'd obviously been to the GP and waited a couple of months before being referred, and that was a very torturous few months, wasn't it? So I'm thinking about the health and well-being aspect as well as the treatment itself, and specifically the moment that your world caves in when the consultant tells you you are actually, unfortunately, having to deal with cancer. And I just can't imagine how difficult it would be for a person to absorb that information by themselves. So does the NHS have a policy of encouraging would-be patients to attend with a partner or a friend so that those questions that they would have asked but forgot to because they were so overcome do get asked? And what do we do about that? Because it's never just the patient, well, sometimes sadly it is, but quite often it's the family and beyond who go through the torture as much as in fact, sometimes more than the person undergoing treatment. So what do we do in terms of thinking about the mental health of those going through this process? Is there anything specifically where we encourage people to come along with a partner? And since over a quarter of people in Worcestershire did not get any treatment within the first 2 months, what are we going to do about that? And this is your opportunity, is there a need for greater resource, national resource coming into Worcestershire to deliver a better outcome? Thank you.
I will make a start. So, very fair, yes, there are more than 25% of patients who have cancer who don't start their treatment within 2 weeks. That varies depending on what sort of cancer it is. Some tumour sites have much higher rates than others, which clearly means some have much lower rates than that 73% as well. I think it's important to be candid in that way. In terms of have we got enough capacity and have we got enough resource, I think that it always is the same thing. For some of those pathways, we definitely have got enough resource. So that some of them we definitely could do with more. A lot of that is about the workforce. It is about, I'm going to use the opportunity, it is about further robotics, because it is, and it is about access to some of those things that we do not provide locally, and nor should we provide locally, but actually having enough resource in some of our tertiary centres, such in that we work with in Birmingham, in Coventry, in Wolverhampton, and in Gloucester, that they're able to treat what is a growing number of these really specialist cancers that we still shouldn't be treating locally, because the overall number will never be enough that it would make sense for our clinicians to treat them locally. One thing I didn't touch on, which sort of links to that, is actually for me one of our big challenges overall is around access to oncologists. So we have a brilliant, a very committed oncology service, often, almost always working above and beyond what they are required to do in terms of their contractual position, because they're committed to delivering for our patients, from consultants to radiotherapists to our team in the systemic anti-cancer treatment. Most of you may know that as chemotherapy, but I will get told off by the nurse if I continue to call it chemotherapy. In terms of what they're doing, so there is absolutely more we need to do in terms of some of the workforce piece that supports some of these services that will inevitably become more and more needed as we see more and more patients with cancer. In terms of the mental health point then that you touched on, there are we would always encourage people to come to hospital with a loved one or somebody to support them. Whether I can lay my hand on an actual policy that says so, I will have to go away and check. But it is certainly usual practice in the majority of our services anyway, whether they're cancer or not, where it's appropriate, that people can bring a loved one with them. For that very reason, in terms of hearing messages and supporting them through that. But part of that support, where patients maybe don't have somebody or they have more questions, does come through our wonderful cancer nurse specialists, who often do go into these clinics when consultants and members and team people are telling people bad news, to help them to guide some of those questions as well. It's never the same as having a loved one in the room who knows you, who knows your personal circumstances, but it is somebody else who can support patients on their cancer journey and to signpost to all the other things that we do have in place, the Macmillan support hubs that we have in our hospitals, the support networks that were referred to by your colleague as well. But I can go and check on the actual whether there's a policy written down.
Thank you very much indeed. In terms of capacity, Chris, and in terms of the robotics, is there a plan to invest further money into the robotics? Because we see the benefit of that, absolutely, but also about capacity within the hospital system in these very specific services, please.
Yeah, so as I said, we've got one robot for surgery that we are now using more and more, 7 days a week often, in terms of what that looks like. The next stage, being led by our Chief Clinical Strategy Officer, is the development of what our robotic strategy looks like. Because for me, this isn't necessarily about investing in one more, it's more than one, because and it's not just about the cancer treatment. So I guess that strategy will come forth in due course in terms of what that looks like, but there is definitely a plan developing, and we have actively been seeking funding through various pots that are made available from NHS England in particular, in terms of how we might be able to fund further robotics developments.
Sorry, just one final question for me. Have we got a time scale on that at all? Because I think what residents are very keen to understand is how we progress this service around and enhance our cancer pathways.
We're expecting to see the strategy in the next month or two. It's such that should funding become available this year, we would be in a position to at least bid for some.
Would you be in a position then to come back and talk to us about it at a later date, please?
Yes, certainly.
Thank you. Thank you very much. Right, next question, Councillor Mark Ward, please.
Yes, thank you. And thank you very much for your presentation. I note your screening programmes, which are excellent in terms of what you do. But I don't see anything in terms of, for example, prostate screening, where there are more deaths in the UK from prostate cancer than breast cancer. And I wondered if you had any strategy in terms of screening for prostate cancer, even in those higher risk groups with family members with prostate cancer. So I'm just curious.
Thank you. I'm aware of a lot of national discussion about prostate screening. This is a national, you know, all these screening programmes come down. It was only in the last 2 to 3 months I was at a meeting in Birmingham, I'm just trying to recall it off the top of my head, about that there is a potential for a national prostate screening programme, which we would obviously take part in. It is quite, it can be seen. We do have the PSA, the blood test now, so that is all there, but there is a more intensive screening programme that can be done, but we've yet to have information about that. As soon as we can, as soon as we do, we will come and bring that to you. But obviously all primary care are commissioned and are contracted to undertake blood tests to test early prostate problems, and they do that very successfully. I know the hospital has seen a huge increase in prostate referrals, it's one of the ones that we've seen, definitely.
How is that blood test? Sorry. How is that blood test actually conveyed to members of the public, either those at higher risk of prostate cancer due to family things, or new cases, as it were?
Mm-hmm. So there has been, it's through primary care largely, so any interventions over 50, over 60 checks with primary care for males. There have been work, I think, through the buses as well, the healthy buses in the county, to encourage hard-to-reach populations to go for a PSA check, etc. Their doctors explain it to them. And through, I know through some community groups in some of our areas, not all the areas of the county, do work with the public on getting your blood test for men, go and get their blood test for PSA screening. There hasn't been as much nationally recently. There's been a lot about the breast screening. There's even been, you know, the bowel screening has been a major issue. We have yet to see that real national push on urology and prostate screening, which I believe is coming.
I'd welcome that. I mean, I have to say the robotic surgery works very well.
Thank you very much. I think we've got Chris Byrne at the back who'd like to speak from Healthwatch.
Yeah. Hi, everybody. Chris from Healthwatch. We've been working with the Worcestershire Prostate Cancer Support Group doing surveys on men who've approached their GPs about PSA testing. Please go and have a look at our website for the reports on that, and I'd be happy to talk to you about that in more detail. Overall, it depends on how those men ask the question when they arrive at the GP surgery. If the men know what they're asking about, they tend to get a good outcome. Sometimes they get turned away, and there's variability out there that we found from our survey. I think there's a need for education. There's a need to prime the men, particularly if they're at risk. And I think it's incumbent on all of us really to be more aware about the risk. And we're obviously talking about family members who've had prostate cancer, but also on the female side, there's a link out there as well for men whose mothers have had breast cancer as well. So there's information that is needed to be understood out there. So a piece of work, I think, probably for public health, GPs and the ICB, GP surgeries, and us as well, to actually get those messages out there.
Yeah, thanks. Thank you.
Thank you very much. Come back to you, Chris. Sir Chris Hoy is a case that's been very high profile in the press. Didn't fit the threshold for having testing, battled to get his PSA taken, etc. I suppose on a localised level here, what learnings can we take from that in Worcestershire, and what reassurance can we gain from his sad situation and the learnings from it, please?
I think some of that comes to what Mary's talked about in terms of the commissioning position. But what I can say is every time somebody like Sir Chris is in the press, our referrals go through the roof. That's clearly not a technical term, but we do see an increase in referrals, and we do find more patients with cancer as a result of that. So whilst I don't want to encourage us to be overwhelmed, I do want patients who think they have got any symptoms to make sure they do go to their GP and do push to make sure they get the right tests in terms of it, because the sooner we catch all of these cancers, the more likely the survival rates will be better for individuals.
And one of the things, and I will open it up to everybody else in one moment, but one of the challenges I've had in my inbox is that somebody is a frequent flyer back at the GPs, and the GP not pushing forward and them saying, look, I'm not happy with this, I'm still not, my flow's not right, my PSA's come back normal, how do I progress the investigation, please? I just want to be checked.
So I guess from an acute provider point of view, that's quite difficult for us to have any real control over. That said, we do have regular interface meetings with primary care where we're working with them in terms of what that looks like. We also locally accept referrals for a PSA that's less than that's different to the NICE guidance. So actually we accept referrals from a wider range than the NICE guidance suggests we should. That clearly causes some challenges on one point, but actually does mean that more men are eligible to come and have further investigations done through urology. So absolutely happy to take away about pushing again with primary care in terms of what those things mean for our local populations in terms of what that looks like, and I'll get the relevant members of the team to pick that up.
Brilliant, thank you very much indeed. So next I have Councillor McSweeney, please.
Thank you, Chair. Very good timing. I wanted to come in on this. I think possibly the reason we may have put this on the programme and I requested cancer screening. I listened to something on Jeremy Vine. I'm sorry, national media, and he was talking about prostate cancer, and there was somebody from Worcester who spoke on the programme about the fact that he had survived, but his friend hadn't because he hadn't been caught in time. And so it's one of the things. I've done a bit of research on the screening, and I appreciate the difficulties of it, the issues with false positives, and the fact that it's not that great necessarily. So actually the false negative is sort of relatively concerning in terms of the PSA test, but it seems like it feels like it's what we have. And I will just comment on the sort of false positive, false negative, that to somebody who's a statistician, I do statistics. I appreciate people maybe don't understand how huge an impact it actually has on in terms of when you get diagnosed, the chances of you actually having the disease. It's quite strange in the way the statistics work, but I was just going to sort of a couple of specific points. One thing that hasn't been mentioned is there's an issue with the BRCA gene mutation, that sort of whether that's higher risk and whether those should be particularly be put forward for screening. But then also I would sort of the comment here I've got sort of about the screen, obviously the sort of the benefits of a screening programme have to outweigh the disadvantages, but I say what I found here, sort of some studies found that screening with the PSA test could mean fewer men die from prostate cancer, but it would also mean that, and I will just go into the things below here, but it struck me that, okay, we've got fewer people dying, and then we've got some buts, which the sort of contrast is some men would have a biopsy which caused side effects. A large number of men would be diagnosed with slow-growing cancer, which would cause these symptoms. Some of these men would have treatment they didn't need, which could cause side effects. Now, it strikes me that all of these things here are fundamentally issues with how we deal with a test afterwards, rather than actually the idea of having a test and doing a screening programme. I'm trying to work out what my question at the end of this is. Fundamentally, it's is there a possibility? I appreciate very much it's a nationally led thing. Is there a possibility of sort of considering what we do locally?
I think your description shows the complexity of the whole issue with this, and screening programmes take some time to get right nationally to get the best effect for individuals. Apart from the PSA, I can't see us doing anything locally on a screening. We need that expertise and signed off nationally to implement. But I think there is quite a strong view, and I'm sit on the Cancer Alliance, the West Midlands Cancer Alliance. There's a strong view from the Cancer Alliance. This is a priority now. Now we're getting lung cancer screening across the region and country. Prostate national screening, because of the limitations of PSA, and there are some limitations to PSA, that has got to be the next priority. But I feel we'll have to wait for that to come down to implement.
Do you have a supplementary, Councillor McSweeney?
I have a question on something completely different to prostate cancer. I come in with that now, or a completely different
point?
point?
Go ahead, please. Go ahead.
It was just on the. Again, I think like most people, probably all of us here, we've experienced cancer. I've just been flicking through my last messages from a very, very close friend of mine who died almost exactly 3 years ago. She had cancer metastasised to her brain. It was originally sort of lung cancer. It had been lung cancer, which had maybe the correct thing would be gone into remission, but she had been cleared, and then it came back years later, just in terms. You kind of sort of talked about sort of living with and beyond cancer, but there's not a lot of detail here about sort of how we deal with those who are in remission, and what sort of the programme is in terms of sort of catching the cancer coming back. I'm conscious that we've heard that there was a possibility that it might have if the reoccurrence had been caught sooner, it might have avoided metastasising. And I'm sorry, I'm going to stop at that point before I get too teary about thinking about my friend. So
We're obviously very sorry for your friend, for your loss of your friend. Mary, please.
Thank you. Yeah, and all patients diagnosed with cancer and treatment and then going forward, it's important that the ongoing screening happens and they are educated as any symptoms come back. And there's, in my experience working in the hospital, there's usually a very good follow-up rate, and following those patients through to the specialist nurses through that specialty. But sadly, this does happen. It does happen. You know, cancers come back, and often second time they come back, it can be very difficult. But if you compare to where we were 10 years ago, you know, the treatments are much more effective than they were then. The outcomes are improving, not as fast as we all would like, but they are definitely improving. It's just that education to individuals. Come back quickly if you feel there's an issue.
Thank you, Mary. Councillor Taylor, please.
Thank you, Chair. This question statement, really, but there is a question at the end of it. Probably aimed at, from Councillor Wells's question about mental health, it's probably aimed at Lisa as well as the NHS. We all hit at some point, as we all know. Personally, I am currently at the moment with a close friend, and we think about the patient, of course. But as Tom alluded to with mental health, we remember to think about the families. But some people don't have much of a family, and in this particular case, she's a single parent. So I'm actually going to take it away from the patient a little and talk about the child whose mum's got cancer. What is public health and the NHS doing to encourage children to talk at schools or whatever it is, to children to talk, and not necessarily just counselling, but so they, I mean, they're scared. Children are scared anyway. You know, there's specifically certain age groups going through puberty, etc. And then they hear this awful news about their, in this case, a single parent mother who doesn't have much of a support network. What are you doing, and if now, currently, and this isn't just locally, of course, this is nationally, but locally is where this is, and what can you do more of? Because this particular individual I'm talking about hasn't really spoke to anybody, and I appreciate, as a sort of young teenager, they bottle a lot of it up and keep it in. But I just think they're probably just as scared about losing their parents, because that's what we talk about with cancer, how terminal it is. I think if you could answer that and sort of give me an idea of what you are doing or how proactive you are. Thank you.
Thank you very much. I'm going to hand over to Dr. McNally, who I know wants to talk about health and mental health regarding this matter.
Yeah, I was really pleased that, I was taking lots of notes on Councillor Wilde's amazing story, and then Councillor Wells and Councillor Taylor have both talked about the mental health side of cancer, which is massive, absolutely massive for the person who is directly affected by cancer, but also, as many of us know, the family of people who have lived and sometimes unfortunately died with cancer. So in relation to generally in adults, and I'll come to the children, as you know, we have a large community development project, and we do fund a number of groups that support both people with cancer and their families. In fact, we met, didn't we, at Bromsgrove as an amazing breast cancer group. And it was about emotional support, but actually it's a lot of practical stuff as well. Some of the things we've talked about monitoring symptoms. They were swapping ideas around what pillow to use, which is important if you've had surgery. And so if anyone here knows of any cancer support projects that public health could support with funding and or promotion or whatever they need, then let us know. We already do quite a few, but we always want to hear about more. And we never say no in public health. And I think the point about children, Councillor Taylor, is brilliant. And I confess we don't have anything specific around cancer. What we do have is a large number of mental well-being and mental health programs for children. As you know, for example, we work with schools. We give our health and well-being grants to schools for them to develop their own programs within the school around mental well-being and, well, around any well-being, but half of the grants that we get in are for mental well-being, unsurprisingly. We have the Mellow service, which of course can support young people. But, you know, why don't we make an outcome of this meeting? Why don't we do something specific? And we can talk to you about that. Maybe we could put out a call to schools or other services to apply for us for funding and support to develop projects specifically around that. That's a gap. Let's fill it.
Absolutely, and continuing the conversation about Ladies Fighting Breast Cancer, a wonderful charity that do bags that people can take to the hospital when they're having treatment. It was wonderful, and when we went there, you could see people just wanting to support the charity to grow it. In terms of supporting young people, that's really important. Not only with cancer, but with a terminal illness, be it a neurological condition, etc. They very often become the carers, and they are really the ones that need some support. Mary, please.
I think this would be a very good outcome from this committee, I agree. I think working with our hospices, who are sometimes the best place to do this, and I know they do as individuals with families and children, support greatly, but I'm not sure it's consistent enough. So I think if we could discuss that, that would be helpful.
I think we have an action, and we love actions, don't we? But thank you. Really appreciate your input. Thank you, David. Right, next on my list, I have Councillor Eacock, please.
Thank you, Chair. Mine is about a different cancer. It's about esophagus cancer. I lost my husband through it. He had no symptoms. He just got a bit of indigestion. So he went to the doctor, who then sent him for an endoscopy. And they found out that he got esophagus cancer. There was no screening, nothing. He had no idea that he had it. He just said, oh, I'm getting a bit of food stuck. So we went up to the doctors, and 7 months later, he passed away. Now, we were told that the only way they could identify it was through endoscopy. He'd had loads of blood tests because he was diabetic, and he was at the doctors for a few years. Is there any other tests? Because now I'm hearing other people are getting esophagus cancer, and there's no, apart from you read on the internet, there's no paperwork or anything out in surgeries or hospitals anywhere. We couldn't find anything, only what we looked up on the internet, and then that was quite frightening. So my question is there anything in the pipeline in the future to identify it? Also, we found out after that his brother had had it. Now, my husband was a smoker, and they attribute it to smoking, but his brother wasn't. His brother was older. And is there any way you can identify whether it's family inherited, this sort of cancer? Thank you.
Thank you very much, and I'm sorry again for your loss too, Councillor Eacock. Really awful.
Thank you,
Mary,
yeah.
please.
And, you know, unfortunately, esophageal cancer is another very difficult cancer, a bit similar to sort of progression with pancreatic cancer. I'm not a clinical expert anymore. It's been a few years since I've done this, but as far as I know, there isn't any, apart from an endoscopy, there is no way of finding, or a scan, they can find it on scans, or predict there's something wrong on a scan until they get a specimen. But again, it's that encouraging, you know, acid reflux, any weight loss, get to your GP as soon as possible. Be very clear of your symptoms, and then there's a pathway, a quick pathway in to get the test that you need to. But I know nothing nationally that will change that. The experts would be somewhere in a darkened room, so when looking at this, but and you know, genetics across all the cancer pathways is something that's looked at, and genomes is something that's in the 10-year plan. Do you know? But you know, affecting people today, I'm unaware of what that would do. Okay.
Thank you very much. Councillor Wild, please.
Yeah, thank you, Chair. I'm sorry about the monologue earlier on. I'll speak more naturally now. I've actually been, as a carer, through 3 cancers, same patient, lymphoma, bladder cancer, stem cell transplant, and now pancreatic cancer. So what that says is you've been fantastic at saving the patient who was given a terminal diagnosis 15 years ago. So this is a positive outcome from it. But going back to mainly you men who were talking about the prostate cancer, the lymphoma developed in the prostate. It was an unusual lymphoma, but it was thought that it might be prostate cancer. However, and this is the message really, the one thing that a man will not do is go to the doctors because they're all joking about the rubber glove. And they don't want that where the sun don't shine. And you'd be amazed just how many months and years a man will actually not want that. I think seriously with women, we have a lot of intervention with childbirth and everything. We're just a little bit more used to it. Whereas the men, I've heard them teasing each other about this, and it's better to go and have that examination and get diagnosed early than to avoid it, because if you avoid it, your problems could be way more serious. So I just wanted to throw that in, but also thank everybody for the services that they've been offering. It's fantastic.
Thank you, Christine. Prevention is always the best route, isn't it? Thank you. Councillor Turner, please.
Yes, thank you, Chair. We briefly discussed the mental impact these can have, certainly if you're being diagnosed with one cancer or another. But also it is the mental impact it can have when you are referred, say there's a lump appears somewhere and they need to send you for a cancer test. And it's the delay between that particular intervention to getting an outcome from that. And again, we're all talking from personal experience, because that's what affects us quite profoundly. So getting a quick diagnosis is very important, so you can take away that stress level is very important. And what can we do to make sure we can get a clear diagnosis to the patient as quickly as possible? As far as talking about the prostate cancer is concerned, age is one factor. There's not much we can really do about that, is there really? The other one is the family relationship with previous cases being highlighted. Well, that's a sort of can be easily diagnosed. But one thing we can make an intervention on is lifestyle choices, and what are we doing to recommend those lifestyle choices. Thank you.
Thank you very much. Over to you, Chris.
Thanks. I'll certainly start on the quicker diagnosis. I might need some help with the one what else we can do in terms of the second bit in terms of encouraging healthy choices. So again, I think there's different things in different pathways in terms of some of this. So for some of the pathways, I know that patients can access the actual test really quickly. After that, there are a number of things that may contribute to a delay. That might be, depending on the test, it might be how long the test actually takes. If it's a pathological test, sending samples off, for example, it might be how long it takes for the report or the whoever has to do the reporting, the healthcare professional to do the reporting of the test. It might be an administrative delay. All of those are driven by some sort of fundamental challenge around the capacity. Depending on which bit it is, depends on the actions that we are taking in a number of those. So for a lot of the pathological diagnoses, so we had samples sent off, bloods, etc. Actually, we've got some of the best reporting rates within 7 days in the West Midlands. Doesn't mean it's right though. So over 75% of results are back within 7 days, generally, for the pathology for patients with cancer. But like I said, we might know that, but how quickly do we let the patient know is something we still need to work on, because that's about how we do that. So the other bit we are doing is is planning for different results in terms of how we let the patients know, and also what suits the individual. So as part of work in some tumour sites, we are engaged in projects that will say to patients, if the result is positive from a patient point of view, actually, do you just want us to text you? Some are really happy for that. In some tumour sites, we're still looking at standardised letters that do the same thing. Other bits in terms of how we use healthcare professionals differently. So a nurse ringing and having that conversation with the patient over the phone is often quicker than sorting out a full appointment in a hospital. The problem with all of that, though, that probably means that if you're invited back to hospital, you sort of already know what's going to be told to you. So there is being really mindful about what that also means. We haven't got it right. It is about getting the capacity in the right place and working with patients that works for them. The thing that, as part of the 10-year plan, we'll see more and more of is use of things like the NHS app to do some of this. But we've got to get that right so that we're not giving bad news to somebody via impersonal text message, is my view.
Thank you very much indeed. Councillor McSweeney and then Councillor Taylor, please.
Yeah, thank you, Chair. I'll just say I've received a message from Councillor Fordington Mel, just saying apologies for leaving, but she's saying that your story, Christine, particularly affected her, and I should sort of offer my no more. I think I sort of kind of missed out before to offer my sympathy. It feels all wrong to say this. My sympathy in your direction. I appreciate. I've noticed that, Chair, that you're sort of being affected by this as much as we all are as well. Anyway, so I have a message from Mel, basically saying, asking me if I can raise this for her. She's saying, obviously, it's a bit of personal details, so I'm not going to go into too much. She's saying in her family she's got breast cancer as well, and it's sort of quite affecting her. The question she wanted me to ask for her is, what can we do to support this as councillors?
Thank you very much, and thank you for, we hope Councillor Fordington's okay. It is distressful when you look around the room and you see the number of people that have currently have fighting the cancer battle or on the cancer journey or have been through it. It really is. Okay, I don't know, I'm handing over to here. Dr. McNally, am I handing over to you? Sorry.
It's not the first time you've called me Councillor McNally. I think it's everyone's worst nightmare, isn't it, me standing for election?
Excuse me, I think I kind of missed a bit off what she said there in getting through that. She says, we as councillors need information to feed to our residents. What can we do to support this as councillors?
Yeah, no, absolutely. It's a great question. And, you know, I've been around Worcestershire now for 3.5 years, and I've never worked at a council where the councillors, the elected members, have been so active in supporting public health work. So to a large extent, you're already doing it. For example, many of you have helped advertise our grant programme, which enables us to support groups in the community, including the schools. Councillor Taylor's just come up with another idea, which is another thing you do. A number of our best programmes going on at the moment have been originated by councillors, and there's another one that will kickstart. I think raising the lifestyle issues that Councillor Turner mentioned is something you can always do. There's no getting away from the fact that lifestyle does cause cancer. We know that. Prostate cancer, for example, is linked with diet and exercise. So lots of vegetables, especially broccoli, dark green vegetables, can help physical activity. Smoking less so in terms of the onset of prostate cancer, but actually increases your risk of dying from it. So all of these issues are important. So keep flying the flag to support people taking control of their own health through their lifestyle. And yeah, and come to us with ideas is what I'd say. If you've got something that you think we should be doing in terms of getting health messages out, whether it be about NHS services or public health programmes, come to us and I bet you we say yes to do it, and then promote Healthy Worcestershire and all the other programmes that can support people to maintain their health and deal with the effects of illness when it strikes them.
Thank you, Dr. McNally. I have two more speakers, Councillor Taylor and Councillor Wells, please.
Thank you, Chair. We're fortunate today to have the NHS, of course, and Councillor Eacock, and fortunate at this stage to have Councillor Nick Price, the Cabinet Member for Transport as well. So I have a question, and I'll come to that question just shortly. So I volunteer for Age UK. It's a befriending service. I see a gentleman once or twice a week. He, 80 years of age, sadly his wife passed away a few years ago from cancer. The difficulty he had, and this is not just directly linked to cancer, but it's actually more linked to terminal illness. His then, of course, wife had to go to Worcester, where she, I think, finished the rest of her life. He struggled to get to Worcester, so this is not just a kind of cancer thing, it's more of a transport thing. And we have an on-demand bus service in Worcestershire. My question would be linked to kind of all these different portfolios is, there may be something in place, but is there plans, or would there be plans for certainly anybody whose partner or somebody in the family has terminal illness, to help support them to visit their partner, wherever they may be it in hospital or elsewhere? And if there isn't, would you consider at least looking into that, please?
Thank you very much. Councillor Price, please.
Thank you, Chair. Councillor Taylor, I just want to personally thank you for your work that you're doing in the volunteering with the Age UK. I've done a bit with my mother myself, and I know how difficult it can be. In terms of the transport, so Worcestershire On Demand operates in a zoning system. So the one thing we are looking at is how we can link the zones together. So, for example, with the gentleman who needed to go to the hospital, we are looking at a pathway to link those zones so we can get people going to the hospital. It's quite complex and it's very early stage work, but as soon as we get through the detail of it, we'll bring it forward, and I'm happy to share some of that information with you, and we can have a further discussion if you'd like.
Thank you very much indeed. Access really is very, very important, and I'd certainly welcome that. Councillor Wells, please.
So I also said this in the last agenda item, really, because it goes across both. I took the decision, Chairman, last year to allocate my divisional fund entirely on the basis of health and well-being. So that was the criteria. I stuck it out there on social media and said, this year I'm focusing on health and well-being. And I was inundated with amazing applications, and it was striking how much is already going on out there in our communities in support of this agenda. So the healthy mamas who do an amazing job, and I should have mentioned it earlier, for newborn children and their mums and dads. But it was beyond that. It was things like the Over 60s Keep Fit Club, the Zumba, whatever that is, club, and so on. I could have spent the money 5 times over, but it was just something I share with fellow members that was something I did last year, just to badge the divisional fund in terms of health well-being. A lot of it actually endorsed what's going on in our village and town halls already, actually, and they ought to be all regarded now as health and well-being hubs, I think, because that's actually, when you look at what they do in their timetables, that's what they do. It's all about health and well-being. And this is the voluntary sector, once again, stepping up. The person who has the initiative to set the, whatever it might be, the coffee morning for the young mums, and whatever it might be. So that worked for me, and I just wanted to share that with everybody, and I'm probably minded to do it again.
Yeah, I've done the same.
Your health impacts on every aspect of your life, so absolutely it's the right and proper thing to do. And I think all of our monies that are spent would fit under that criteria, if I'm really honest with you, because we're looking for outcomes. the best outcomes for our residents. Chris Byrne, you've just raised your hand.
Yeah, I just wanted to raise the profile of the Health Zone app. On page 15 at the bottom it says link to app. I don't know how many people in the room actually clicked on that link. If you want an action, could I ask all the councillors to click on that link on their phones and put the app on their phones and talk to their constituents about the benefits that app can bring to them. So for example, I've got the app open on my phone at the moment, and it talks about support groups for cancer patients. One of the big things that happens, of course, is where do patients go, where do carers go, where do families go to get trusted information? And it's a nightmare out there, obviously. So this is a website put together by Macmillan. So the information on here is trusted information. So if you want to know about support groups for head and neck cancer, then this is the place to go. It also talks about practical financial information, emotional well-being, physical well-being. It also talks about the clinical teams. So I'll give you two examples. So this month, on here, it talks about what's going on locally. So for example, Worcestershire Oncology Walking Football Group had an event in April this month. Prostate Take Control Workshop on the 21st of April. Worcestershire Breast Haven, and I could go on. There's all these activities going on, so you can tell your constituents this is where the support actually is. There's people out there doing stuff already. Please go and have a look. Thank you.
Thank you very much, Chris. You raised a really pertinent point, and we will do that. We've added it to the list. We're going to do the final points that we've raised now. Any further questions before I move to what the recommendations? Mary, Chris, thank you so much. Thank you for your attendance this morning, and also thank you for all you are doing. We know that cancer's a journey, but it's the smoothness of the journey and accessibility to both services and that ongoing care that we all require. So, from this meeting, Councillor Wilde is to be provided with feedback from the pancreatic support group, or you're going to provide it to Mary. Absolutely. And please, any help we can give you going forward, please do reach out. The NHS policy on taking a loved one to cancer appointments, that's going to be checked by the ICB to see if we're advising to take somebody along as a pair of ears. Add robotic strategy to the work programme, please, Chris. We'll look forward to that and the developments in investment. The ICB to remind primary care colleagues that in Worcestershire referrals regarding the PSA levels are at a lower level than the NICE guidelines. By that we mean that we're not sticking wholeheartedly to NICE guidelines. If you've got symptoms, please, we need to get the help you need. Members advise the Director of Public Health of any cancer community support groups that are out there, and also around young people, the service that we can, and the support more importantly. Thank you, Lisa. Oh, excellent, it's actioned already, we love actions. And members to promote the Cancer Services app to their residents. Thank you all very much. It is a difficult subject matter. And recommend that the DAPH considers in consultation with the ICB how support can be provided to children and young people when a loved one is going through a cancer journey. I think that's what Lisa's already actioned. Yep. Thank you all very much. Thank you for your time. And thank you to members of the panel. It's a difficult subject matter, I know, and it absolutely resonates with everybody in the room. And best wishes to everybody that's going through a cancer journey and their loved ones too. So the next agenda item is the work programme. We've discussed potentially around special educational needs children needing further advice around nutrition. We're going to do a piece of work on that in the background before we bring it back as a potential subject matter. I'll take it up afterwards with the DPH and the team. We had a conversation, Dr. McNally, regarding children, young people with special educational needs suffering in terms of nutrition. So maybe I'll pick up with you outside. Thank you. Thank you, Claire. I hope your leg's better soon. So for the June meeting, we have urgent patient flow, including urgent community response service to include virtual wards and West Midlands ambulance service. And we have neighbourhood and the health and the impact on their long-term conditions, and of course the work programme. Thank you to everybody who's watched this meeting and taken part today. It's been a difficult one, but subject matters that are really, really important to our residents. Take care. Thank you. Thank you.